Hi everyone, I'm Gary Mitchell. I'm a GP, work in Dunedin. I like to work remotely as well. Uh, Thanks for inviting me to your conference. I'll try and zoom in as well. I'm currently working on this island you'll recognize from the photo. This is Pitcairn Island. First thing I thought to bring out here when I was thinking about the things I might need for a remote assignment was, apart from my toothbrush, my ultrasound. So one of the things I've worked out over the last couple of decades is that ultrasound's not just for using in remote places where it's incredibly helpful. You don't have X-ray, you don't have tests of a lot of kinds. You're relying on your clinical skills. Ultrasound gives you that extra window, that extra level. But now sometimes I work as a GP just in like downtown city, like in Dunedin. Might do a locum here in the middle of town. Got my ultrasound switched on and working in my general practice, and a day doesn't go by where I not only don't use it, but don't use it and find it helpful. Like you, I work in emergency departments, urgent care places, as well as general practice. Um, and if you've heard me sort of warble on about ultrasounds before, you know, I like doing fast scans. I like looking at the heart. I'm interested in checking gallbladders and that. But I find those difficult. You know, there's a tricky ultrasounds, and I'm kind of become convinced that musculoskeletal ultrasound is the way to start. If you're thinking of getting into ultrasound, or if you're not yet doing it, it's I find easier and gives you instant rewards. Very quickly becomes a vital tool. Here's an example of where ultrasound can take us forward. See in this picture, you've got this bone here. This is that lump of bone. This is callus. This is how we should be. Well, one of the ways we can check for callus or check for healing. You can X-ray, but a lot of the time you can just do a scan and you'll see a lump of bone. It's unmistakably callus. And even more information than that, you can see vascularity, right? So maybe able to get that to play. You see all this, look at all this vascularity around here. Now that's a sign of an actively healing area of broken bone, and you will often see vascularity on a scan before you see callus. Or if you do an X-ray and it looks like delayed healing, put the scan on and see whether you've got a lot of blood flowing to the area. It's a good sign. It's like an added thing that you can demonstrate to the patient. Sometimes you don't need to do X-ray. You wouldn't need to X-ray this. You can see the alignment is okay. This is a metatarsal with a nice hunk of new bone. Plenty of case say to the patient, look, doing fine, and carry on with your management. Let ultrasound take us a little bit on from our old ways. There's another metatarsal dilemma, very common. We see this in general practice too. Like somebody comes in, they've got a sore foot, it's been sore for a while, and nobody can get a diagnosis. They've been to the fracture clinic, X-rays are normal. You put your scan on and you actually give the patient the probe, tell them to put it on where it hurts, save you the trouble. Put it on, and there's an organizing sort of a hematoma on top of a little bit of callus over a stress fracture that's invisible. Remember, with X-rays, you get very limited. They usually only take 2, at the most 3 views, and you won't necessarily get an angle to spot a wee bit of callus, especially on the foot, because you've got all these other bones on the lateral side obscuring things. So I would often find fractures or abnormalities, bony abnormalities that are not visible on X-rays. You've got this dilemma. What do you do? Well, in this case, it's simple. You just tell the person they've got a stress fracture and you manage it. Sometimes you see things that's hard to convince, say, the radiologist that there's actually an issue, like a chip off a cuboid or a talus or something that's a little bit subtle like that. Sometimes those things are easy to see on scans, and you've got to decide what to do. But my point here is just get on and scan these things, and sometimes you get the answer well before you've had time to fill in the X-ray form. Okay, Here's a slide that took me a bit of doing here on little Pitcairn Island. It was a bit of a challenge. I know all of the other presenters in this conference and 90-something% of the audience are smarter than me, maybe more experienced at all this stuff too. But so I won't get away with it, but I'll give it a go. Here's an idea. Look, Ottawa ankle rules. Let me make this brief because I haven't got much time. It seems to me that we go through all these rules. You look at the age of the patient, how many steps they can or can't take, and how sore they are down the lateral malleolus region and other parts. And I've had that quite a few times happen, and I've gone through all the rules, and then finally I've said, oh, by the way, they have a fracture on the scan. Or, by the way, the scan shows that they don't have a lateral malleolus fracture despite being tender there. And then it makes me wonder, you know, what are we doing all these rules for? Why don't I just put the scan on and say, look, you know, there is a fracture or there's not a fracture. Very easy to see. You can see a little crack there. That's what a crack in the lower fibula would look like. Then it made me think, well, you know, sort of same for other things, you know. We spend a lot of time deliberating about this. Most of us are already doing this, of course. We're putting our scans on abscesses or cellulitis areas to see, is there an abscess? Is it a decent size? Is it ready for incising, or should we aspirate? How deep is it? And all that. So a lot of these protocols, I'm saying, they need to be centered around the scan. Yes, we still do our history, our exam, but the scan is critical. And it not only helps us diagnose, also helps us manage, doesn't it? It helps us direct the needle to the abscess if we decide to aspirate, and we can check that we've sucked out all the pus that's there and bring them back and do it again the next day or day after, or if we decide to incise it. So that's one point. And then the point after that is that actually, sorry, that's not a abscess, that's a ganglion. I just didn't have a picture of an abscess over here. So I'm sure you would have picked that up. And the other thing, of course, that's not a fibula, although that's what a Weber B fracture looks like on a fibula, or a Weber A if it's a bit higher, or a Weber C. That's what they look like. That's actually a rib fracture. Oh, sorry about that. Look, I think my point is that there are times when point of care ultrasound becomes like one of the most important things that we're doing for the patient. And a lot of what we do next hinges on it. And it should be, point of care ultrasound should be elevated into one of the first things that we think of, and can often shortcut the diagnosis and the management of the patient. And, you know, buccal fracture is a good example. Here's the buccal, you know, the distal radius, there's the buccal. So we don't need to x-ray these anymore. You can see it on a scan, just put it in a splint. There's other things that I think, well, a whole vast range of things that we can, that will change in terms of our protocols. You know, the Ottawa protocols for ankle are going to, should they include ultrasound, or should there be a protocol for situations where there is an ultrasound and situations when there's not? We're getting this sort of separation happening, aren't we? Achilles injuries. Clinically, most of them you can get them right, but not always. I've seen Achilles that have been casted up for a few weeks when they're not actually ruptured, and I've seen Achilles that are ruptured but not casted, and a scan sorts it out immediately. UCLs are my favorite, kind of small UCLs, thumb sprain UCLs. You can, very difficult to check in the acute phase, you know, to know in the examination when they come in, is that second degree tear or is that a complete rupture? And I've seen them missed, and I've seen them diagnosed the other way around as well. And a decent ultrasound will sort that out. And our pocus machines are getting better and better at these things. Knees, you know, you see a knee injury, we can look at the MCL, we can look at the LCL, we can look at the patella for fractures, we can look at the patellar ligaments, we can look at the quads, find small effusions. You know, it seems like there is so much extra that we're offering our patients. And some of these protocols, like the Ottawa ankle protocol we talked about before, some of these protocols might be different if you're a somebody that uses a scan or not? Should there be a protocol for situations where you've got one? There's this sort of separate thing happening, which I think is all going to evolve into, ultimately, you can see it, can't you? We're all going to be scanning, we're all going to be doing this all the time. And to me, that's just one thing that's exciting about being in this whole field. You can see it unfolding. This potential for scanning everything is right here and right now. Here's another one just to demonstrate this. So finger, proximal phalanx, X-ray normal, and on our scan we can see a little disruption in the cortex there. You know the management's a little bit different if you spot the fracture. We often miss fractures on X-rays. We find them on scans. One more, here's your typical clavicle fracture. You can see exactly what the angle is. You can see where the fracture is. You can see it's not displaced. And then you can just manage that, pop it in a sling. Why would you X-ray that? Get them back in another week. Check the angle hasn't changed. Check it hasn't been displaced further. Get them back a few weeks later. Look for callus. Look for vascularity, new bone, and that's how we manage clavicle fractures. Okay, so here's your DVT. In your proximal greater saphenous vein as it enters the deeper system in the groin. Pretty good at diagnosing these things now. Is to have a bit of compression. You can see the deeper vein compresses, but the DVT doesn't. So these proximal DVT is quite good at spotting these. If you have a DVT, what do we do with our protocols? You have a DVT, just treat it. If you don't have a DVT, proximally, might be distally, you're not sure, you can either get a definitive scan, or as some places do, just wait a week, bring them back, do another scan, make sure it hasn't extended proximally. At that point, if it hasn't, it's unlikely to sort itself out without treatment. Or if you're not really sure, you can just scan them again another week. Just monitor it. This is a great thing for general practice. These things don't need to get to secondary care, just like our fractured clavicle never needed to go past your general practice. We could have sorted this out. This is the way forward. I don't think we're getting controversial here. These are things that we do as GPs in remote areas. And, we don't have hospitals. We don't have referral options. We want to manage our patients safely. We put a scan on, the transverse scan on an extensor tendon around the wrist. We see the dequer veins. We see the fluid around it. We can slip a needle in there under direct vision and put in the steroid. Nothing needs to go beyond general practice. You do this in your emergency department. You do this in your urgent care as well. It's another example of how we can just take things on. Of course, we're not throwing away our X-ray machines. Your distal radius going down towards the wrist joint down here somewhere. You see there's a fracture, elderly person, and you can't be sure where this fracture runs. Maybe it runs across, straight across, maybe it angles up, maybe it's intra-articular, maybe there's an intra-articular displacement. We are getting better at sussing these with scans, but that's another level. We still need to X-ray this, and although we might get just as good a look at the angle and the displacement, there are some things that we don't necessarily see. So I think while we're getting more and more sussed with these techniques in emergency medicine, urgent care, general practice, we still need to remember that the X-ray is super helpful if we have it available for this sort of thing. So just a reminder, proceed with a little bit of caution. And a final reminder, you scan, put the offending limb under water, especially if it's a small thing, a hand, a foot, and use your standoff technique. You might not need to go to the extent of this, but of course, number 3 on the list of important equipment to take to pit care is your snorkel. Thanks for listening.